So good evening, everybody, to the second webinar on the lower limbs. Today, Martin Wiewiorski is going to present on Hallux Valgus Reconstruction. And we have a couple of information for those who are new and with us for the first time. You can participate in this webinar through the chat. Just leave a message, be precise as much as possible with that question that you would like to ask. And we will come back to you at certain times when we have question and answer sessions. You can also raise your hand if there's something urgent that you would like to clarify by trying to do that from the back or forward it to Martin Wiewiorski at a certain time. And otherwise, I wish you a joyful time. And, well, I hope that you like this webinar. Please give us your comment anytime you wish, and feel free to join whenever is useful for you. I will just hand over to Martin Wiewiorski now for giving us his talk. Thank you so much.
Yes, thank you very much, Patrick, for this introduction. I'd like to thank the IBRA Foundation and the guys from IBRA, Lucas and Patrick, who are managing this webinar tonight, which I'm holding from Winterthur in Switzerland. So the topic today is Hallux Valgus Reconstruction. And this is just an introductory slide about the functions that you have during this webinar. So what I want you to know is that, of course, I can see you guys, and the interaction is not so easy. But in between the sections of this talk, I left some space for question and answers, and also we'll have some polls that you can participate in. Just a few words about me, because most of you probably don't know me. Just a quick history of my career. Well, I went to med school in Münster, Germany. I started out as a research assistant with Victor Valdelabano in the University of Basel. I started my residency in a traumatology department in Bochum, Germany. I continued my residency, did a fellowship with Victor Valdelabano in Basel. I took my board exam by the end of 2014. I did a research fellowship at Harvard University, and since May 2015, I'm a consultant and the chief of the foot and ankle section in Winterthur, in the public hospital in the conference. So this is the agenda for tonight. Basically, I will talk a little bit about primary hallux valgus. I don't want to talk too much about it because I think most of you have done some, at least have a basic experience with some hallux valgus reconstruction. But I also prepared a few cases for you, revision cases, and there may be some cases about problems that you might encounter during hallux valgus procedures. So this is how my talk is going to be structured. This is the first part, just general things about hallux valgus, preoperative preparation, surgical techniques, just an overview, and a little bit about postoperative care. And I think that this is the part that you joined this webinar for. I'm going to talk about some intraoperative issues you might encounter. Show you some cases of revisions after failed hallux valgus procedures. And at the end of this webinar, we have some time for discussion. The whole thing, I think, is going to be about 45 minutes. Let me talk first about some general considerations of hallux valgus repair. You know, all know basically this is a philosophy. It's a mixture of your own experience that you make during your career doing hallux valgus repair, and you implement observations you did when you observe other colleagues or friends doing similar surgeries. Basically, this kind of mixes in your own approach that you have. There's a vast amount of different surgeries. There's more than 140. One of our residents at one point did a count. It's a crazy amount of different surgical techniques. So basically, there's a lot of ways to skin the cat. I think personally that after you've done like around 150 cases, you start understanding what you're doing when you do a hallux valgus reconstructions. Of course, this talk represents my own experiences, my own philosophy. I'm not going to talk a lot about evidence. Please don't be shy to leave some comments. And though I think minimal invasive surgery is important and can yield very good results in hallux valgus repair, I'm not going to talk about this today. I'm just going to talk about the open procedures. Of course, when the patient comes in into your outpatient clinic, the anamnesis, the questionnaire is probably the most important thing. Most of those patients, they report they have a conflict of the big toe and shoes. They have pain wearing shoes for a longer period. They tried many different shoes in the past. They talk about increases wear of the shoes. They have calluses. They have inflammation of the big toe. Many of them have a standing job. But at least in my outpatient clinic, they rarely report about being limited in their activities, and really, at least in my there's some background noise here coming from somebody. Maybe Lucas, can you mute the other participants, please? Thank you. So at least in my patients, maybe 1 of 50 patients complains about the hallux valgus being an aesthetic problem. So I really have to do surgery for this reason. Of course, the clinical examination is very important. If you need to take a look, generally look at the alignment of the lower extremities, especially the hind foot, the foot and the ankle joint. You have to assess the extent of hallux deformity. And also, of course, you have to look at the deformities of lesser toes that can conflict with the hallux valgus, hammer toes, bunionidal deformities. You have to test the range of motions of all those joints that you see here: TMT joint, MTP joint, IP joint. Of course, the lesser joints, you have to test the stability. You have to take a look at the soft tissues. You see ulcerations, hyperkeratosis. You can see soft corns between the toes. And also, before you do the surgery, please check between the toes. And also some microsis of the toenails. And of course, pulse palpation, I think that's very important. It just gives you a general idea about the fusion of the foot. And I think also something which is really important is to see if the patient is hyperlux, and for that you can use, for example, the Biden score. Of course, basic conventional radiographic imaging, standing views, it's mandatory, it's very important. Usually, if I know a patient is coming in for a forefoot deformity, I do a dorsoplantar view, a lateral view, and an oblique view of the whole foot. Of course, if the patient, you see there's some issues with the hind foot, you can also always do a mortise view of the ankle joint and a Charleston view. What you rarely need is CT or XCT, which is a hybrid of scintigraphy and CT or an MRI. But just in some cases, for example, this XCT is very important. For example, let's take a look at this. This you see on the right side, the DP view. You see this is a moderate hallux valgus, right? Nothing special going on, but the patient also complains about pain in the midfoot. If you take a closer look, you can see there's something going on here in the midfoot. And this patient also has severe osteoarthritis over TMT and 2 and 3 joint, and also osteoarthritis here between the os naviculare and the medial cuneiform. So in this case, I would actually do a SPECT CT. This is the SPECT CT of the patient that you've seen here, and this is just coronary reconstruction, where you can actually see all of those TMT joints, and you can see that all of those joints increase uptake of the tracer, meaning that the osteoarthritis active here, and this, I think this changes also the indication for your surgery, because in this case you don't want to only correct the hallux valgus, which is bothering for the patient, but also want to address the TMT 2 and 3 joints. So in this case, for example, you might do a TMT 1 to 3 fusion. So a SPECT CT or a CT can be really helpful in some cases. So all orthopedic surgeons like to take some measurements on the X-rays, so it's probably important. You can see on the left side the list here of all the measurements you can basically do in this kind of X-rays. Especially, I think the most important one is the preview. And this is the order of measurements, which I think is also the order of importance. For me, the most important angle is the intermetatarsal angle. Basically, this is almost like the only angle that I'm looking at. And of course, this is between the lines drawn along the first and second diaphysis of the metatarsals. And also take a look at this, because I think this is really important when you look at this. The center of rotation of this deformity is basically all the way here in the terminacular joint. Other measurements you can take, which are also very important for your operative planning, is the distal metatarsal articular angle, the DMM angle, between the diaphysis of the first metatarsal and the articular surface of the first array. Then many people focus always on the Hallux Valgus angle. I don't think that's actually that's important. This is never a problem really to correct for a release. But yes, you can measure this. And another angle, which I think also is not really important because you can always decide intraoperatively if you will correct this or not, is the proximal phalanx articular angle. Other things that you have to look at, which are really important, and also important for, especially for making a decision what kind of surgical technique you want to use. You have to check for osteoarthritis, especially of the TMT1 and FTP joints, and of course you have to respect other deformities like pes plantar valgus. You have to check if there's luxation or subluxation of the joints, not only an MTP1 joint, but also of the lesser toes. You have to address in the surgery. Here below, we can see this is basically the standard application of the Hallux Valgus. And as I said, for me, this intermetatarsal 1 and 2 angle there, I think this is the most important one. I'm not really looking at the other aspects of this classification, which is a simple classification, basically subdividing Hallux Valgus deformity into mild, moderate, and severe, and was introduced by Coughlin. Additional preoperative measures that you have to do, especially if you can't palpate a pulse during the clinical examination, or you see where effectively check for sclerosis of the arteries and radiographs, the patients may have a known peripheral arterial disease. I think you should perform a duplex sonography, and maybe the patient even needs intervention before surgery to make sure that all the osteotomies or fusions you do actually in the skin can heal. So there's enough blood supply to the foot. If the patient has any kind of like onychomycosis mycosis or interdigital mycosis, I think you have to treat that. Either you use local treatment, sprays between the toes on the toenails, or even in some severe cases, systemic treatment for 3 months. And usually those patients also let them wash the week before the surgery once a day with a disinfectant soap. If the patients have severe calluses, soft corns, or maybe neglected nails, you have to usually send them to a chiropodist before the surgery so they can take care of it. I don't know what you're doing. Normal Hallux Valgus surgery, I usually don't check the vitamin D levels, but if you can do this. I usually just for checking the level, just put the patients on vitamin D before and 3 months after surgery. So this is the first part. So I will stop here for a minute. So maybe you can ask some questions to this first section if you'd like to. Maybe Patrick and or Lucas can moderate this. Because I don't really see the comment function here. Yes. Any questions from you guys?
So far, there's nothing yet. If you have any questions or if you have any comments, please put them down now, as precise as possible if necessary. I also would like to remind all of you, please, to check if your microphones are muted, because there are sometimes interferences in the sound, so it might be easier to listen for everybody when everybody's mute. But there's one question.
Patrick, can you please read it, because I cannot see the comment function here. I can't blend it in here. I don't know where it is. Here it is. Chat. Okay. All right.
Instability and preoperative assessment. Thanks. From Miroslav.
Yeah, Miroslav, thank you very much for this question. I mean, this is the question that basically is asked every time. Well, I mean, I think it's. I not say it's not important. I think it's important. That's why I don't know if you saw it. Just like in the preoperative assessment, in the clinical assessment, the patients always check if the patient has some kind of laxity, especially in the sagittal plane or in the coronal plane. If this is a hyperlax patient, because I think this is really important in the decision of what kind of procedure you want to do. I think, especially in the moderate hallux valgus, this is you have to basically decide if this is something that you need to address by a fusion of the TMT1 joint, or if you can get away by a distal osteotomy of the first metatarsal. So I think this is definitely your impression that you have on the clinical examination of the patient before the surgery. And if you have a moderate hallux valgus in an older patient, older, probably older than 35 or 40 years, in this kind of patients, I would probably go for a TMT1 fusion, but at least this is my opinion on this, and there's many opinion. This is a very hot topic. Basically, you will hear about in any kind of foot and ankle conference, in any session of hallux valgus. I know this is a very general answer, but I think this is something that you also have to find out for yourself and make your own experiences as you go along as a foot and ankle surgeon. The other question is, what about sesamoids? I think that's, I don't know exactly what you mean by sesamoids. The sesamoids are subluxated in the hallux valgus, at least in my opinion. I think the sesamoids, when you look in the dorsoplantar X-ray, I think basically they show you the original position of the metatarsal head where it started out. So I think this is an important landmark for you during surgery, because I think the goal of any hallux valgus surgery, whatever procedure, bony procedure you do, is to place the metatarsal head back on top of the sesamoids, and not the other way around. Release the sesamoids all the way so they can force under the head. I think this is because I personally don't believe there's a shortening of the intermetatarsal ligament that connects the sesamoid to the second metatarsal. I think the sesamoids are your reference of the original position before the hallux valgus deformity.
Martin, there's another post by Craig. How long before the patient sees a local general practitioner about the bunions to being referred to you?
You mean how many? Basically, well, this depends on the general practitioners. Like many of those general practitioners, especially in the area around my hospitals, they I would say like 1 or 2 generations before me, and they made poor experience with some Keller-Brandes surgery, some crazy surgeries they did like in the 80s and maybe early 90s, because back in those times nobody did care about hallux valgus surgery. Nobody did want to do it, so there was not really a concept for this kind of procedures. So I think they made some bad experiences. So I have many patients that have been to the GPs for many visits until he actually sends them to me. And but on the other hand, like some younger general practitioners, they know about the surgical options, and basically the low risk of hallux valgus surgery. They rather send those patients to me, for example, after the first visit. But of course, I see a lot of patients that they come to me, they just want an opinion. Thank you, Frank. Yeah, exactly. They want to know about conservative options, and there's not really a lot of conservative options. At least in the adult hallux valgus, which is the most patients I see age 16 or more, which are basically with fused physis. There's nothing much you can do. Like, this is a mechanical problem basically. Those patients have a conflict with the shoes. There's no real way by physiotherapy or some kind of splint to reduce the weight of the forefoot. So if they cannot manage with wider shoes, or they cannot wear wider shoes or really comfy shoes because the job is expecting something else from them, they have certain dress codes. So basically the only way to reduce this mechanical forefoot width is a mechanical correction of the forefoot. All right, I think, some questions? Thank you. Okay, all right. So I think I'm just going to continue here and go to the next section, if that's okay. Oh, okay, one more. Miloslav's got one more question here. He's got a good experience with physiotherapy in means of spiral stabilization, in means of preventing a hallux valgus progression. I don't know if this is the question. I don't know exactly what you mean by spiral stabilization. There's of course other conservative measures you can take. it is a conflict of the bunion with the shoe, so you can wear wider shoes. You can reduce the inflammation with some non-steroidal drugs, some gels, and all this kind of things. Of course, I mean, there's some place for conservative therapy in Hallux Valgus. You don't have to do surgery on every patient. Also, you don't want to do surgery on every patient. Combination of pre-op and post-op. Okay. Tiago, I think we talk about the surgical techniques in the next section, so maybe we can talk about this the next answers on the next section. Okay, thank you. All right, let's continue with the close the chair. Let's continue with the next section. Okay. All right, surgical techniques. You don't need a lot of instruments. I mean, I usually use just a large blade for a skin incision and a small blade for everything else. And I also do percutaneous minimal releases of the extensor tendons or the capsulotomy of the MTP joints. I usually use the beaver blade for that. You need, I think I recommend this. You need the small bone power tools. Something that you could basically see on the right side. I'm personally using right now a system by Synthes. It's an E-pen driver, but I'm soon probably switch to a Synthes core power tool system. Whatever you're comfortable with, basically. Just make sure you have really sharp saw blades, because you don't want to have like shitty old blades, basically, because you do the osteotomies, you need sharp blades, because if not, then you're gonna force it, you're gonna create some false planes, and this will basically affect the outcome of your surgery. This is what I'm using to fix basically any kind of Hallux valgus surgery. I personally am using the implants by the company Medartis, which is a Swiss-based company in Basel. What I need is usually cannulated compression screws, which are the CCS screws, either size 2.2 or 3.0. Also use regular fully threaded corticalis screws size 2.3, but I also use small self-cutting, self-drilling compression screws, which are the 0, especially for the lesser pose. If I have to fix, they're really nice if you want to fix a wild osteotomy, or maybe a correcting osteotomy of the fifth metatarsal. And of course, you're going to need some plates. And I'm using this up to 2.8 plates. You can see on the bottom side here. So of course, any kind of Hallux valgus surgery, whatever you're doing, any open procedure is going to start with the soft tissue approach and the soft tissue release. Typically, a dorsal-medial approach is performed regardless of the technique, and the length of the incision may vary. I do just a skin incision, then I do with another blade a sharp incision of just the superficial fascia. I do a lot of hemostasis on the way there. Personally, I prefer to work with a tourniquet. After I incise the superficial fascia, I do a blunt tissue separation to dissect the tissue down to the deep fascia, to the capsules and to the periosteum. And then after I've done sufficient hemostasis, I perform then the capsulotomy of the MTP1 joint. And then the next point is the lateral release. And I, over the time, learned to work sequentially. I'm not the type of guy that just says, okay, lateral release, you have to just like cut every tissue that is around there, and that's it. I made the experience that basically you have to do this sequentially. You can, of course, there's different approaches to this. You can either walk through the same incision to the MTP joint that you would do the osteotomies or fusions later. You can, some people do a separate interdigital incision. Some people even go and prepare over the capsule. I release through the joint inside the capsule. And this is how I go. I do a stepwise release. And first, which I do is I release the capsule and the ligament complex of the lateral side, which is basically made of the structures you can see below here. Don't be mistaken, this is the medial side, but the lateral side basically looks the same, not much different. So what I do is I basically go with the blade down here and under the lateral collateral ligament and under the lateral metatarsal synovium with the capsule, and I release all the structure from the metatarsal head. This is the first thing we're going to do. And then I check what's going on with the MTP joint. Especially with patients that are a little bit hyperlax, you would find this is a completely sufficient release. You don't have to go further. If I see this is not sufficient, I can still continue. I can do here a parallel incision of the capsule. And if this is still not sufficient, I can still go and do a tenotomy of the tendons, of the adductor tendons. So I think this is the right approach to do it sequentially, because you also risk less hallux valgus deformities, which are really debilitating for the patients and lead to quick degeneration of the joint. So maybe see also quickly some pearls. I think you should take time for the soft tissue preparation. It's only maybe 2 or 3 minutes more, but your patient will like you for that. You will have, if you just preserve those, especially this dorsal medial vein that runs along the upper border of the incisions on the TMT1 joint, MTP1 joint is always the same vein. I find the patients have less swelling if you do enough hemostasis. If you open the tourniquet after your procedure and do sufficient hemostasis, then you will have less swelling, less bleeding, and the patients will just have less swelling and will go from quicker, and you will have less wound complications. And also, as I said, I prefer to do a stepwise release of the soft tissues. If you do excessive release, you can have a hallux valgus. We'll see a case later, and I think this is really a big problem, to repair this. Also mind, there's also a nerve, the dorsal medial nerve branch. And I mean, I don't have a lot of patients. I mean, I'm sure I've cut it before. Maybe I haven't seen the nerve, but the nerve has seen me. But there's the saying. But patients not really bothered by it. But why not preserving it? I mean, why not make the surgery 5% or maybe 3% better for the patient? Bone correction. We talked about this before a little bit, and you can see I brought this here of the goal, because I think eventually this is the goal of every bony correction in hallux valgus. You want to get the metatarsal head over the sesamoids. You don't want to try to release the sesamoids and force them over the metatarsal head by performing like easy releases or just tightening up the capsule on the medial side, because I think that's cheating. Especially, I think, at least my philosophy is, if you end up doing the surgery at the end of surgery and you don't have and you think you need to force some extra correction out of the capsule on the medial side, and you probably undercorrected it by bony correction. You haven't performed the adequate release of the sesamoids. So as you can see, I mean, there's many techniques, to do this bony correction. And as I said, the German saying is many ways lead to Rome. There's many ways to skin the cat. I think if you're comfortable with any of those techniques, it can lead to a great result for the patient. But I think there's some. Of course, there's some techniques that I prefer, that I'm doing on a regular basis, and also mine, and also I'm a teaching hospital, and there's some other techniques I'm not doing. I haven't done it before. I haven't tried any one of those 140 techniques which are available on the market, because I don't think I will do my patients any favor. And I try to summarize the most common procedures that I think are being performed for hallux valgus surgery, which I just classified in 3 groups. One would be the distal osteotomies of the metatarsa, would be the chevron or the different modified versions of the chevron osteotomy. I also counted in the Aiken osteotomy, and of course the MTP1 joint fusion. Then it's the more middle to distal osteotomies of the diaphysis, and which also include the metatarsal head, which is, for example, the osteotomy, or the reverse L or Revel osteotomy. There's some more proximal osteotomy. Pedic osteotomy, there's open closing wedge osteotomies at the base of the metatarsal. Of course, there's the Lapidus fusion, which is the fusion of the TMT1. I just want to quickly talk only about 3 techniques: the chevron osteotomy, the scalp osteotomy, and the MTP1 joint fusion and Lapidus. The first one is going to be the modified version of the chevron osteotomy. Personally, I've been trained with this osteotomy in Basel with Victor Zalavano. I know that Victor is still performing this osteotomy. I switched. I'm performing now more the scalp osteotomy. But I think it's commonly performed especially in North America, and it has shown some good results. And I think it's got some advantages. Also, it's got some disadvantages. Basically, what you do is so how is the osteotomy done? You can see it here on the left side. You will find the center of the joint. You you do a cut up, and you do like an oblique cut, basically to the proximal metaphysis. The original chevrotoscopy goes down here, and for example, the revelostomy is also modified version, goes all the way down here, more parallel to this diaphysis. But this is like the modified version. So basically, when you look from above, you can see this one cut. And it allows you, especially in the mild, or maybe even in the moderate hallux valgus deformity, it allows you in this kind of cases a sufficient correction of the hallux valgus. But so what I draw here in blue is basically this is your contact area of those fragments, right? So this is not much contact area. So basically, how do you fix this? I would fix this, or for example, Victor in Basel is fixing this with this CCS candidate compression screws I was talking about, size 2.2. Basically, you can put 2 of the screws here in the head, not bicartilagar. Those screws, they sink here in the bone. They have like it's a double thread, and you can sink them in the bone. And here, and they looking from above. Basically, there's a ways to do this. I mean, you can, if you have enough space here, you can put them here in a parallel order. Or if you don't have enough space, you can also, I've done it before, you can put them basically sequentially. So looking maybe from this view, like two screws in a row, which allows usually a sufficient fixation in this kind of posture. This is a patient which, because I'm not doing this, I have done it recently. So I asked Victor to send me a case. So he sent me this very nice case. Victor, thank you very much for this. And so this is a patient, this is a 73-year-old female patient. She's got I would say like a mild, moderate hallux valgus deformity. This might be, I haven't done any measurements on this, but I would say something a lot like 13, 14 degrees of deformity here. So of course, as we said, you have to look at other problems here. And what I note first is there's some osteoarthritis already going on here in the MTP1 joints. The joint space a little bit narrowed here. Here it's still okay. You see some osteophytes here. Here on the lateral view, there's osteophyte here. But also what you note in the patients is also this problem. She's got a severe osteoarthritis of the of the talonavicular joint. That's maybe something that you want to address in the same surgery. And this is what Victor did. And this is after the surgery. There should be around 6 to 9 months of the surgery. And you can see basically he performed here the chevron osteotomy. He shifted the metatarsal head by around half of the width of the head. So he had enough space to put two of those 2.2 screws. He performed an Aiken osteotomy to correct the hallux valgus interphalangeus. As also you can see, he used some larger CCS screws, which is probably here 5.0 screw probably, and a 7.0 screw to address the talonavicular joint and perform the fusion into healed nicely. So we talk about the patient already discussed some osteoarthritis. So I haven't seen this patient personally, but also I've got this kind of patients in my practice. And I mean, some of those patients then don't really complain about pain coming from the MTP1 joint. So they do complain more about the bunion, and you have to differentiate that on clinical examination. And in a case where the patients have a very good range of motion, I mean, I don't see a reason why to just fuse the joint. I mean, if this joint deteriorates further over the years, you can still go back and do it. But of course, maybe some of you would just go and do like a definitive procedure and correct this with the MTP1 fusion, which is of course feasible. The next thing I want to talk about is the scarf osteotomy. This is the osteotomy I perform probably more than 95% of my hallux valgus cases. I think it's a very versatile osteotomy, because you can use it for mild deformities. Also, you can use it for severe deformities. And over the years, I also pushed it. And I would say right now I could perform the surgery even in a patient with an intermetatarsal angle of up to 20 degrees. But yeah, you have to get there very early. So I think the good thing about this, if you look at the literature, many people complain that you can not use this osteotomy to correct the MMA angle, for example. I think this is not true, because for one reason. So at first, maybe how is this osteotomy done? I guess you guys seen it before. You find the middle of the head. You go just 1/3, 2/3, and this is basically your starting point for the upper cut, which is a little bit oblique. And there's a long cut, basically to the lower third of the diaphysis or metaphysis, also like around 2/3, 1/3, and there's you have to do like with a reciprocal, so you have to do a oblique cut up here. But this can vary, and in the later case, I'll show you why this makes a difference. Because basically, by the length of this osteotomy, you have also the chance to correct the DMMA angle. If you do the osteotomy long, let's say you're very close to the base of the metatarsal one, so the center of rotation of this osteotomy is here, and basically you can swing this metatarsal all the way over here. I think it's a very powerful osteotomy. If you have here, for example, a DMMA, which looks like this, more like a juvenile hallux valgus, you wanna do your osteotomy over here, because then maybe you just wanna shift this whole segment parallel, and maybe you can wanna even rotate it out to correct the DMMA. And I think that's really feasible with this osteotomy. I just done a case today, which I had to do a short scalp osteotomy, and I had to derotate the fragment to establish the DMMA. So that's why for me this is very, very, very versatile osteotomy. You can really push it. So basically, here you can see, and it basically has a very large contact area, or larger than a chevron osteotomy. But I've done patients which maybe had like a contact area of almost just the cortex here. So over the time, you learn how to fix this osteotomy and how to push it, and there you can use it to correct even more severe hallux valgus deformities. Maybe about the fixation. So what I do here is I usually, like in the chevron osteotomy, I put one of those CCR screws here in the metatarsal head, and here I just use a regular bicortical screw to the 2.3 screw to fix this osteotomy. Also, of course, I mean, if you're comfortable with, which is also like traditionally done, you can use also two bicortical screws here, or even some people use here CCS screw, which I'm not preferring to do. So basically, maybe just to show you how a bit of the intraoperative approach here. So this is a patient, this is a typical patient with the Hallux Valgus Juvenis. This is a kind of like a typical configuration of the X-rays. Those patients have a, mostly they have a, maybe this is just exaggerated, but they have a pathological DMMA, yeah, and they have a congruent situation of the MTP1. So this is a congruent Hallux valgus. You can see it better when you open up the joint macroscopically when you look inside the joint. So basically, the goal of this is not to use this as a center rotation and swing the whole thing over, because then you will have not corrected the DMMA, which should be in the end parallel to the articular surfaces of the second metatarsal head. But you have to make a short osteotomy, which I did here. So basically, try to swing this proximal part a little bit more out, which I think I managed in this patient. As you saw before, I fixed this screw on here with the cortical 2.3 screw, and also I mostly perform, in most of the cases, probably more than 90% of the cases, I perform an 18 osteotomy. And here you can see the fixation on the lateral view. This is an intraoperative view. So again, this is the basically this is 1/3, 2/3 intersection, and I usually you saw it on the last X-ray. I put here the K-wire, which should be 90 degrees to the second metatarsal, and point to the second MTP4 joint, and be slightly downwards, like around 30 degrees to the sole of the foot. So this is basically how you can see all those steps here of the osteotomy. So this is this patient. You saw one actually before. Actually, this was a bilateral procedure. I think, like especially like in this kind of cases where patients have a light to moderate hallux valgus, it's really easy to do bilateral procedure at the same time. They can go into weight bearing with crutches for 6 weeks in a shoe with a stiff sole. So this is feasible. This is also young patients, and I think I managed to correct this deformity in a good way. The sesamoids are like in the correct position. You can argue here there might be a little bit of overcorrection here, but I think when you look at the, it's also, one thing is the X-ray during the surgery, but think about it. I mean, it's not a weight bearing. The X-ray during surgery is never weight bearing, so you still have to basically make a your own. You have to look at the foot, and have to just think if it is it balanced or not. So even if you think there's a little bit too much hallux valgus here, when you look at the postoperative clinical examination, which is I think it was like 4 to 6 months after surgery. I can't really tell you. The swelling has gone down after the surgery. I think that is still okay, even if this is maybe not a perfect X-ray after surgery. The next thing I want to talk about is the Lapidus fusion. I think this is, of all the surgical techniques to correct the hallux valgus, I think this is the most powerful technique, and I use this for 2 patients. If they have a severe deformity, which is for me personally more than 20 degrees of intermetatarsal angle, or if we talked about before shortly, if they have a moderate hallux valgus but have a hypermobile TMT1 joint on the clinical assessment. And basically this can be done in 2 different ways. Basically, you have the classic original Lapidus arthrodesis, which is a fusion of the TMT1 joint, and a fusion also combined with a fusion of the base of the TMT1 and 2 joint. This is the original procedure, and usually what I do is I do a flat cut, sparing flat cut here of those surfaces. So I have a good 2. This is a relatively big joint surfaces. Yeah, when you look at this joint, and so you have nice 2 spongylotic areas. Which what I do first is I correct alignment, and I introduce a screw this way into the medial cuneiform, and you look here would be probably something from here to here, and it could be any kind of screws. You can use one of the CCS screws, the 3.0 screws. Sometimes if I don't have an available, you even use a regular 3.5 cortical screw. So there's many ways to fix it. I think this is the most important screw because it gives you the compression and this gives you the basically defines the alignment of the joint. And any kind of fixation you put on top of it, and I'm using this Aptus 2.8 plate. It's just a dorsal plate which goes into this area. I think this is basically. This is secondary. It gives you rotational stability, but the most important thing is this compression by this screw, at least in my opinion. Maybe you can do a quick poll here, because I'm wondering who of you does the original Lapidus fusion and who does the modified fusion. So maybe I can just go back. A modified fusion is basically just fusing the TMT1 joint without fusing the base of the second and joint. So maybe you just quickly poll here. I'm not going to spend too much time here. Let me put this up for you. I don't know if you can see this. Patrick, can you see it?
No, not yet.
Not yet? Okay. Why not? Try it again. All right, here we go. Maybe don't want to spend too much time here. Maybe. All right. Okay. Come on, guys, please vote. Need a few more votes here. 10, 9, 8, 7, 6, 5, 4, 3, 1, 0. All right. I hope you can see the results here. And so you see, 27% always do the modified TMT1 fusion. I am one of those people, actually. I'm always do the modified fusion. Some of you, 70%, do the TMT1, the original fusion. But many of you, 57%, they use the intraoperative decision, and I mean this is definitely seems to be the way to go. So basically, what you do is just after you fuse the TMT1 joint, you can apply some compression between the first and second metatarsal head, and you do this under X-rays and dynamic a way to test it, and you can see if the basically the space between the medial and the intermedius cuneiform just opens up. You know, there's some instability there, and you can still do the original fusion. Or if not, if you don't see any instability, you could just leave it and leave it modified. It seems to be the way to go. I personally, I don't really think this is true. I always do the modified fusion, but if you ask some other people like Victor and Bas, for example, he will tell you that you should test intraoperatively. And so far, I didn't encounter any problems with this kind of approach. Okay, so I'll just continue to the next slide. So this is drawing here. What's going on here? I didn't draw this. Okay. I don't know if you see these red lines on the screen. It's, I don't know. Lucas, can you see this? These red lines here? I didn't draw them. They just appeared. Patrick?
Yeah, I do see them, but I don't know where they're coming from.
I don't know. Okay, just let me quickly restart the presentation. What the hell is this? Okay, now they're gone. Now they're back. What's going on? I have to restart the presentation quickly because I don't know what's going on here with this. Sorry for this, guys.
Bildschirm freigeben. Und,
ja, versuche ich gerade, aber das Menü fehlt mir.
Und unten an der Taskleiste, in dem Fenster.
Ich sehe keine Taskleiste, das ist das Problem. Zeigt mir nicht mehr an. Okay, I see it. All right, here we go. Sorry, guys. Okay, all right. Can you see it again, Patrick?
Perfect.
Okay, thank you. All right, sorry for this. So this is a case I want to show you. This is a severe hallux valgus. Also, you can see as the pronation of the first toe. And I would say like 21, 22 degrees intermetatarsal angle, no osteoarthritis, maybe slight osteoarthritis of the MTP1 joint. In this case, I performed a modified TMT1 fusion, also combined with an echinostomy, and I think this yielded a sufficient clinical result in this case. So this is how I fixed it. I talked to you before about that. So first I put after the resection of the surfaces, I put this compression screw, the CCS 3.0 screw, and on top of that I put the lapidus plate. This is what you basically get after you've done resection of those. So this is an intraoperative look, how the plate looks like. Here's the entry point of the CCS screw. I'm just gonna go quickly over this. This is the MTP1 fusion because I talked already way too long. It's already 45 minutes progressed into the talk. and I want to talk about the complications, right? So, of course, you know, the MTP1 fusion, the fusion of the base of the first proximal phalanx and the first metatarsal. You can do this basically in any kind of deformity when the MTP1 joint has osteoarthritis. So this is a more severe case of hallux valgus. This is a patient which also has rheumatoid arthritis. You can see she's got the ulcerations, the calluscus, the rigid hammer toes, the rigid IP joint. There's not really any range of motion in this big toe. It's basically an functional forefoot. So this is how it actually looks like. Looks a little bit crazy, and basically all the MTP joints are luxated or subluxated. So I think this is nothing where you can use like any kind of chevron osteotomy or maybe even scalp osteotomy. This is something that you also, because the MTP joint is severely degenerated, you have to fuse this joint. So I did this. So basically, this is how it looks like. This is the patient just came in 2 weeks ago for a 6-week control. This is a standing X-ray. So I resected and had to shorten the MTP and the IP joint, and I've transfixed both joints with this I think CTS, which gave me a good compression, and on top of that I put this this fusion plate, Aptus fusion plate. There was no way I could restore the MTP 2 to 5 joints, so I just did a resection of the base and then FP heads and transfixed them with K wires. Resected the IP joints of the toes, and basically I did a hormone fusion, and so this is how it looks like. This is actually the clinical view after 6 weeks, and I think this actually looks like a foot again if you compared it to the preoperative sedation. Lucky enough, I didn't run in any soft tissue complications in this procedure. So maybe to go quickly over the postoperative rehabilitation. So any kind of distal osteotomy of chevron or scalp osteotomy, I put the patients immediately into full weight bearing. It's tolerated. Some of them need crutches, but none of them come with crutches in my outpatient clinic after 6 weeks. I use this stiff post-op shoe. They don't require any DVT prophylaxis. And then I advise patients to start active and passive range of motion with the TOR by themselves on the second day of the surgery, and I do usually controls after 6 weeks and 3 months. Any kind of fusions of the TMT1 joint or the MTP1 joint, I put them in the immediate partial weight bearing, 20% body weight for 6 weeks. And you can use any kind of below knee walking boot. First 6 weeks with crutches, those patients usually require some DVT prophylaxis. I use just oral rivaroxaban, Xarelto, for 6 weeks. After 6 weeks, I do an X-ray, and I put them in a regular shoe with carbon fiber insole for another 6 weeks. And I also do controls after 6 weeks and 3 months. Okay, because of the time, because of progress time, I'm gonna maybe skip the question and answers here, and we just but please note your questions, and we're gonna answer them by the end of this talk. And I'm just not gonna quickly continue because I think this is a interesting topic. So we talk about intraoperative issues, and one of the issues you can encounter during any kind of this osteotomies is intraoperative fractures. This is actually a case which happened to me around 4 or 5 months ago. Nothing special. A healthy patient, 32-year-old lady, regular body weight, good bone substance, and I don't know exactly what happened here. Maybe when I started manipulating here the osteotomy, then what happened is, clack, I broke here the metatarsal head. Okay, so what do you want to do now? You have to fix this, right? I mean, first you have to continue with your surgery. You have to fix you have to continue doing the scalp osteotomy. You have to still get your hallux valgus fixed. And then you have to fix this fracture. So what I did here, I transfixed it here with the 2 K wires. What I did, I put in some 2 CCS screws here from top to bottom in this direction from the articular surface, of course. So I have to take them out after this has healed. And actually, by this, I achieved a sufficient reduction of this fracture. So this is how it looks like. This is this X-ray is 3 months after surgery, and Actually, it looks okay on the X-ray, but also I performed a CT because I wanted to know how this is healing. And actually, because this is only one surgical cut of many cuts, but on most of those cuts, actually, I see that there's some bony healing going on in this fracture side. But of course, you can see there's going to be a conflict here. So I will remove the screws after 6 months. I mean, I think it's mandatory to take the screws out in this case. I will do another CT to make sure it's fully healed. But the patient is doing okay. She's doing full weight bearing. I advise her not to do any sports activities until 6 months until the screws are healed. So this is something which can happen. This is another case. I don't remember if I've done the surgery myself, one of our residents or other consultants. Anyhow, it doesn't really matter. It can happen to anyone, right? So basically, like especially during the scalp osteotomy, you have to make sure that the proximal part of the scalp osteotomy comes out here in the lower third of the thank you. There's another. What the hell is it? Okay, but don't mind those lines. It's not me. I don't know what's going on here. Anyhow, what happened here? Basically, the osteotomy came too far, and additionally, by cutting with the reciprocal saw from below here, I cut very, very close to the dorsal cortex. Okay, okay. Thankfully, I noticed this intraoperatively, and so I didn't put this patient to full weight bearing, so I put him in below knee walking boot for 6 months, and there's another case. I'm gonna. No, wait, sorry. This is the bottom X-ray here. Is actually how it looked like after 6 weeks. You can see already this portion is healing, but he's got some slight callus over here. But the correction is of this callus osteotomy is still intact. So I will do. He's not back to work yet. I'm gonna do an X-ray after 3 months and see how the whole thing is doing. But I think he's gonna. But I was restricted his working and sports activities for another 6 weeks, or a total of 3 months after surgery. Some other stupid things that can happen to you, you know, when you like do your scalp osteotomy, you're very proud of yourself, you did a nice correction, you transfix. I usually transfix it here with 2 K-wires, one here, one here. So over this K-wire, I put the CCS screws, and right next to this K-wire, I do the drilling. So what happened to me is it's like I drill too close to the K-wire, and the whole K-wire kind of like wiggled around the drill. Thankfully I got it out and didn't have like any implications for the outcome of the surgery, but some stupid stuff that can happen to you during this kind of surgeries. I want to talk about some failed procedures and some revision of failed procedures, and I think there's some general considerations here you have to think about. I think before any revision surgery, I recommend you to do a cross-sectional imaging, for example, a CT, to see what's going on in this joint, if there's any osteotomies, are they fused, how is the bony substance, what's going on, is there osteoarthritis. Of course, most of this patient has some kind of hardware, so make sure you have the right tools for hardware removal. But in many cases, you need some kind of bone grafting you have to do, so make sure you know what you need. If you need any kind of autograft, where to get it from in the body, any kind of allograft you use, or any synthetic graft you have. And most of these patients I do a duplex sonography just to make sure that the perfusion of the foot is intact, especially in the revision situation. Sometimes if they have any kind of dysesthesia or any like neurological pain, I send them for neurological evaluation. And all of them have some kind of soft tissue preparation before the surgery. There's soap. Sometimes I even precondition the soft tissues with canisterless vacuum dressing before the surgery. They get lymphatic drainage. Sometimes I'm taking them even before the surgery for 1 or 2 days to do like a inpatient lymphatic drainage, make sure the soft tissues have swollen down. And then in some cases you need to show them to the plastic surgeon because you might be in need of some kind of vascularized bone graft, even, or some kind of
98, that's me, baby.
Make sure you know what kind of revision implants you need, and in this kind of case, I probably would check vitamin D level, especially when I have to revise a fusion. And in a case of infection, of course, you might think about like a 2-stage procedure with a biopsy, the first step, or an aspiration to make sure that you're not operating into an infected situation. So the first case I want to show to you is this patient had a chevron osteotomy. He had a non-union. A 50-year-old female. She had, this was not a scalp osteotomy, she was a chevron osteotomy. 6 months before I saw her, she was a smoker. Compliance was questionable. So basically, this is Sorry about those lines here. I don't know. I cannot get rid of them. So this is how the situation is. So basically, she had this kind of Chevrolet-like procedure, or distal osteotomy. So you can see basically something happened here. She lost the correction, and the fragment rotated medially. The DMMA, the DMA itself is intact, but the whole fragment is just rotated laterally. So she was not happy. So I had to revise this. So maybe I don't know what the reason was for this failure. Maybe the screws were not bicortical. And failed. Maybe she was too weight bearing too early. I can't really tell you what happened here. So I had to revise this. And sorry, this is also the CT. You can see this is basically a non-union here of this fragment. Non-unions in this region happen really rarely. Even I see some heavy smokers at the surgery on heavy smokers, and they really always heal. So I revised it. I basically had to redo the osteotomy and then fix it. And I did this with these 2 CCS screws and 3 CCS screws here. This is the result, I think, after 6 months of the surgery. And I think I could salvage the situation. The patient was sufficiently happy after this. This is another fracture case of the scalp osteotomy. A 46-year-old patient. 4 months prior, she received a scalp osteotomy. Healthy patient, compliant. The surgery was done by resident under supervision, and so this is what happened when she had a scalp osteotomy. But also, I think what happened here, the osteotomy was too far dorsal. The cortex broke, and she lost the correction here, and the whole thing probably healed in a sort of whoa. Okay, malunion. Okay, this is getting crazy here. Holy smokes. Jesus Christ. Okay. Sorry, I have to reopen this again. This is too crazy. Okay, all right. Sorry for this. So, I think the osteotomy was the dorsal in this case. So I did an X-ray, but on this, sorry, a CT. On the CT, I saw that the osteotomy was fused, and so I had to redo the osteotomy. And so this is how I did it. First, I did an open wedge osteotomy here. Just use this kind of like wedge implant to just swing basically the metatarsal, distal metatarsal over back, and then I had to redo the distal osteotomy and also use additional plate on top of this to fix this. And this is 6 months after the surgery. And I think also the situation is sufficient. But in this, this is a lot of hardware, and you don't have a lot of soft tissue there, so we had to remove the implants in a later point. Another case here, this thing is really a severe complication, which unfortunately I don't see too often. It's a Hallux valgus after Hallux valgus surgery. A 25-year-old young lady. She had some kind of osteotomy 6 months ago. Otherwise compliant and healthy, but she has a painful deformity. So this is from the preoperative X-ray, and this is the clinical view. I mean, this is crazy looking, and you can understand why this is bothering her. So I think what happened here, was the release was too aggressive. You can see that this sesamoids are all the way to the medial side. I mean, the osteotomy, the cells, the aching, and the whatever distal osteotomy was done here, maybe a scarf, they healed sufficiently, but I think she was just over-released. So we had to take care of that. I mean, there's many ways to do this. I don't think we have time here for this kind of call. I mean, you can go and just fuse this joint, and I mean, this is the definite procedure. But of course, this young lady, she doesn't want to lose the range of motion. I think that I prefer is I reconstruct the deformity with a tightrope. I do a medial release and fix it. You can do a tendon transfer using, for example, the abductor tendon. Or maybe there's some other ways to fix this, but I did this here with the tightrope. So we did a medial release here at this point, and fix this with a tightrope. And oops, oh, sorry, I'm missing there was an intraoperative view, but I'm missing the slide. Sorry for that. Okay, let's go to the next case. So this is a 46-year-old female. She's got this malunion of the Hallux Valgus surgery. This is a case was sent to me by Matthias Weicher, a friend from Würzburg in Germany. This is was called Stoffella procedure. I haven't done myself. It's the first time actually I saw this kind of surgery, but you can see something is going on here. This distal fragment is malrotated. She was also in pain and was basically was fixed. I think it was fixed in a malposition, and this is how he fixed this problem. He removed this implant. He redid an osteotomy. He probably did here a chevron osteotomy here in the healed bone, and he fixed the whole thing with 2 parallel CCS screws, and I think it worked out nicely. Maybe it's still a slight Hallux Valgus here, but I don't think the patient was bothered by this. There's a case Victor sent to me from Basel in Switzerland. This is a patient. She had many procedures in the history and on both feet, and she was not really happy. 84-year-old lady, and she basically was not able to walk barefoot. She was severely impaired by the deformities. This is how it looked like. It's hard even to describe this picture. I mean, she's got a lot of hardware still going on. I mean, she had some kind of like wild osteotomies here. She had some kind of like, I don't know, hormone fusions, malrotated big toe, insufficiently reduced or basically recurrent Hallux valgus, probably some kind of scalp osteotomy, and a similar situation on the other side. Here, also like the MTP joint subluxated. We don't really know if this was a natural cause, some persistent deformities, or maybe just the failure of the procedure she was undergoing. So this is how Victor solved this problem. I mean, you saw a similar approach in my case with the rheumatoid arthritis. He removed all the heads of the metatarsal, 2 to 5 on both sides, just gave him enough shortening so the toes could basically realign, and he did a fusion of the MTP1 joint, also using his Medartis up plus 2.8 plates in this case, and it healed nicely. Another case that was sent to me by Christian Plass, a colleague from Hannover in Germany. It's a patient, 70-year-old. She had a previous chevron osteotomy. She had pain, poor range of motion, and she developed probably some osteonecrosis and early rapid osteoarthritis after this procedure, basically within 1 year. So the question is, well, what happened here? I think what usually happens when you get this osteonecrosis is that you perform it to excessive release of the plantar capsule, which basically provides the region for the vascular supply of the metatarsal head. We don't really know, but this is what might have happened. So this is how Christian revised it. He removed the hardware, and he did MTP1 fusion, and he didn't want to sacrifice any length of the big toe zone, so he put an iliac crest interponet here. I think it's already a healed situation, but here there was basically iliac crest piece, and it fused after a few months. I think it's a nice way to revise this kind of patient. So this is something which I would like to have your advice on, because maybe we can do actually the poll here, because this is a patient which I have seen recently in my outpatient clinic, and I don't know what to do with this. So this is a patient. She had a Renault or Regnault procedure in the past. I had to look it up. I mean, I did so many procedures I didn't know about this one, but actually people are doing this for Hallux valgus. And this is a young lady, and she's got pain of the big toe joint. She's got poor range of motion, and so this is the clinical view. You see this deformity, and this is how it looks like. So I had to look it up. So basically, the Renault procedure means that you kind of detach the base of the proximal phalanx of the big toe, and you shorten it, yeah. And then he did he resected a lot of the bunion here. I mean, this is probably never resect this much. So anyhow, I mean, there's some osteonecrosis going on here. I mean, I don't know why we would do this procedure. Actually, I don't see rational behind it, but I mean, it was done. And so this is the situation here. The joint is just, the base is gone. It's just mush. And this is an MRI here. It's subluxated. I think there's some surface going on, but the bone is definitely not healthy. I mean, some probably necrosis of the sesamoid is also going on here. It's hard to tell. I mean, there's a joint effusion. So what do you want to do with this patient? She's 26. I mean, I don't know if you. I think I don't see any way to fix this. I mean, like to reconstruct this. I mean, maybe you can do like a big poll here, so what would you do? Would you wait and see how she's in pain, or would you fuse a joint? Some of you would do a prosthesis. I mean, other procedures. Yeah, I would probably would like to know what kind of procedures those are. So, and also I would like to, after we've done this polling, I would like to open up the discussion section. Maybe we can first discuss this case. So, okay, let me close this and show you the results to you. And you can see most of you, 74% would go for fusion. I think this is what I would do too. And I talked to this about this patient, and but she wants to go for a third opinion. And I don't know if you're gonna see again. Maybe she's gonna find somebody who will promise her something else, like in other procedures. So maybe we can open up the discussion now, and maybe the people, the 9% or that did other procedure, maybe they can tell me what kind of procedure this would be. So who do something else than the fusion? Antonio said he did the last one. Okay, I'm glad about that. Well, anyhow, I think I'm gonna fuse this lady because I don't see any other way to reconstruct this. So guys, is there any, okay, with Miroslav, he has a comment here with. Okay, right. He thinks, that there might be some kind of Swanson type interposition implant there. Could be an option. I mean, it could work over time. I'm just not sure if she's gonna be happy with it. If she's actually like she's 26 years old. She's active. I think this kind of implants work really well in the hand because there's basically no way veering. But you have to walk on the big toe. I mean, it takes a lot of from a biomechanical point of view. It takes a lot of like of strain, and I don't think this implants will eventually help her. I don't know. I probably would. I'd rather not go for this kind of procedure, but this is definitely an option to do. I think for her, a fusion would work best because from my own experience, patients with fusions can basically do almost everything. They're not going to win the gold medal in the Olympics in the 100-meter sprint, but I think she's going to be able to do regular sports. Yeah. Any other opinions on this? Or any other questions, general questions, guys? Fusion, yeah, Victor says fusion, yeah. I think that's the right way to go. Allograft joint replacement, all right. Okay, that's something interesting. This is a really interesting option. Personally, I don't have experience with this. I mean, I've seen some patients that received an allograft replacement of the ankle joint. And I mean, like, if you ask some people to do it, they say the results are sufficient. I have no idea if this would work in the MTP joint. I don't know. I mean, like, of course, it's in the range of all joint preserving procedures you would want to do. I think this is an option, but I don't know. This is this will be the way to go here. You might try. I mean, if you have to talk to the patient, and if you can get hand on a fresh frozen allograft of the sufficient size, and the patient is willing to try it and may want to accept a failure after 1 year and do fusion, then yeah. Mario says, thank you, Mario, for the comment. Mario says MTP fusion with structural iliac crest. I think definitely we don't want to accept the shortening because you would probably have to shorten it even more than what you see on the X-ray. Then it will be like really short. I think this is probably the way to go. Just put in like an interpositional graft from iliac crest. That's probably what I would do. Yeah. I mean, think about if you want to do like an allograft, you probably have to also resect some of this bone, and after you resect this, you end up with a really, really, really long defect that you have to take a big iliac crest wedge out to replace this one.
Martin, there have been a question by Trevor. Do you consider rotation of the first met? A lot of surgeons in our area are becoming more focused on the rotation of the first met and like systems that correct the hallux valgus deformity on all 3 planes.
Right. I mean, the rotation is definitely something that you have to consider, and I think it's especially in this severe hallux valgus deformities, it's something you have to also address. But from my own experience, usually when you do, especially when you do a lapidus fusion and you reduce the TMT towards the laterally towards the TMT2, basically you want to get them like more or less parallel. You cannot really overcorrect, and the rotation is of the metatarsal is something which basically corrects automatically. I think even if like uniplanar osteotomies, I mean, like I'm always surprised when I do this calf osteotomy. I don't know, like if it's the same about the chevron osteotomy. I'm really surprised that I do it even in the more severe hallux valgus up to 20 degrees, as I told you, and even with the basically uniplanar osteotomy, which I always do a little bit, you know, like I would say it around 30 degrees plantarly, then I see a correction actually of the rotation. So when looking at X-rays and intraoperatively, I think you can even achieve with this kind of uniplanar osteotomies a sufficient correction of the rotation. But it's not something which I would try to control intraoperatively by placing K wires like in the cuneiform and the metatarsal to actually correct for those deformities. I think that the lapidus it corrects itself, and the scalp osteotomy is also not such a big issue. But this is my opinion.
Two different comments there. Can you read them?
I see intramedullary implant could work here by Nadav. Are we also probably talking about the other case? Intramedullary implant. I don't know exactly what you mean. Do you mean like a Cartiva, for example? Or do you mean like I don't know what you mean exactly, Nadav. Maybe you can specify. Hip on. Okay, I don't know this implant. I actually haven't seen it before. Okay, I can really comment on this. Sorry, Nadav, because I don't know exactly what implant that is. I guess I have to go and check it out during the next Foot and Ankle conference. All right, sorry for that. Sorry, I can't really comment on this. I don't know this.
I have another question on NTP fusion with structural iliac crest.
Yes, right. What is the question? We have a few comments on the iliac crest. Okay, maybe I can address the comment by Miloslav. I think Hallux valgus is a progressive disease with basically it is something. I think it is something which is genetic. Basically, you have a certain predisposition, and I mean, if you have a certain predisposition, if on top of that there comes like some mechanical factors like your body weight, the use of the joint, wearing certain shoes. I think this actually, if we have the predisposition for this, this will actually lead to a development of this progressive entity. And I don't really think, you know, that physiotherapy can reduce hallux valgus by strengthening. I don't really seen it. I mean, I've tried it before, but actually, yeah, they can reduce the symptoms because, you know, what physiotherapists can do really well is just they have a lot of things they can do to reduce the inflammation over the bunion. They do like some kind of like ultrasound therapy or other things, you know, can do to reduce the inflammation. So I would not say that patients do not profit from physiotherapy, but I just don't think, that the deformity can be reduced or slowed down by any kind of training, muscular training, or splints. This is my opinion. All right. Any more questions? Patrick, can you read the question about the iliac crest? Because I might have missed it.
Yeah, that was written by Mario Herrera Perez. Empty fusion with structural iliac crest.
Yeah, exactly. That's what we were talking about. Basically, you just take a piece of the iliac crest which is a tricortical bone, and which is a very good stability, and you can just after resection, after you have basically healthy connection surfaces, you can put this in, and you can fix it nicely, like with one of those revision plates, for example. But you just make sure that you have the sufficient compression. And I mean, some those patients, after this kind of procedure, they basically have to do non-weight bearing for, this is my opinion, for 6 to 8 weeks. I would even put them maybe in a cast if they are less compliant.
Okay, Martin. If there's no other question, we have to close down the session.
Okay, sorry guys, it took me much longer than I anticipated, but I hope you enjoyed the talk. I mean, this is a very large area. This was just my philosophy how to approach this kind of problems, and I hope you could take out something out of this talk, and maybe you can think about it, at least implement it maybe in your own philosophy. So thank you very much, and once again I want to thank Ibra, Patrick, Lucas for managing this webinar, which is of course free for all of you, and hope to see you again in some webinars in the future. Thank you very much.